Today we're going to talk about analgesics. Analgesics are medications that are used to suppress the pain. Pain is actually one of the main reasons people seek treatment. We can define pain as an unpleasant sensation that can either be acute or chronic. Usually, pain happens as a consequence of changes that are happening in our body, such as neurochemical processes. These can happen either peripherally or centrally in the nervous system. Now, there are two main categories of analgesics or painkillers. The first one that we'll be discussing are the non-steroidal anti-inflammatory drugs, and these actually work peripherally, so they're not part of the drugs working on the central nervous system. The next group that we will be talking about are the opioid drugs. And again, these are painkillers, but their target is receptors that are present in the central nervous system. So they will modulate the sensation by modulating or antagonizing these receptors. The name analgesia comes from a Greek origin where ana means without and algia means pain. So these drugs give you a feeling without pain. So a definition of an analgesic or painkiller is any member of the group of drugs that achieve analgesia or relief of pain. These drugs that relieve the pain selectively without blocking the conduction of nerve impulses, they don't alter the sensory perception or affect consciousness, and this is a main difference between analgesics and anesthetics. Now, these agents, they work in various ways, either on the peripheral or central nervous system. Drugs working on the central nervous system are called narcotics or opioids, while we have non-narcotic analgesics, and these are belonging to a group of drugs called non-steroidal anti-inflammatory drugs. So what are the differences between these two categories? First of all, in regards to the efficacy, opioids are much stronger than non-opioid or non-steroidal anti-inflammatory drugs. The prototype of opioid analgesics is morphine. The prototype of Nsaid is aspirin. Opioid can relieve any kind of pain, while non-opioids mainly target peripheral pain such as musculoskeletal pain. Opioids work centrally, so they are drugs that are part of the central nervous system. Pharmacology, on the other hand, non-steroidal anti-inflammatory drugs acts mainly peripherally, but some of them can also have some central effects. The mechanism of action of opioids is they target specific receptors, and these are the opioid receptors. The non-steroidal anti-inflammatory drugs mainly affect prostaglandin synthesis. Important side effects or dangers from the use of opioids are tolerance and dependence. On the other hand, non-opioids are associated with marked GI irritation. Narcotic drug does not possess any extra properties of being anti-inflammatory, antipyretic, or antiplatelet. On the other hand, non-narcotics, they are, as we said, analgesic, but also anti-inflammatory, antipyretic, and some of them have also antiplatelet activity. So, we can classify analgesics into non-steroidal anti-inflammatory drugs, NSAIDs, and again, these drugs work peripherally, so they're not part of the central nervous system pharmacology, but we are explaining them in today's lecture because they are kind of analgesics that we use a lot. We have paracetamol as a separate group. It does actually inhibit the prostaglandin synthesis as the non-steroidal anti-inflammatory drug, but it has some distinct characteristics that we'll be describing a little bit later. And also opioid drugs that mainly target opioid receptor in the central nervous system. So let's start talking about the non-steroidal anti-inflammatory drugs. NSAIDs are a group of chemically dissimilar agents that differ in their antipyretic, analgesic, and anti-inflammatory activity. So they are compounds that have distinct chemical structure that are different from each other. They share common properties, which is their activity. So all of these drugs have antipyretics, so that means they lower the elevated body temperature. They have analgesics, so they are painkiller, and they also have anti-inflammatory activities. Also, they share the mechanism of action, so they work by inhibiting the cyclooxygenase enzyme that catalyzes the first step in prostanoid biosynthesis. So, remember from biochemistry that we have an enzyme called cyclooxygenase. It's part of the arachidonic metabolism, which produces prostaglandin. So, they would decrease prostaglandin synthesis, and when they do so, they would have some beneficial effect that we use therapeutically and also some unwanted side effects. Remember the cyclooxygenase pathway of arachidonic acid metabolism that produces prostaglandin. These prostaglandins have effect on blood vessels, on nerve endings, and also on the cells involved in the inflammatory pathway. So to review that, once we have a stimulus that causes the disruption of the cell membrane, an enzyme phospholipase converts some phospholipids to arachidonic acid. Arachidonic acid is worked on by two enzymes. We have the cyclooxygenase pathway or enzyme and the lipooxygenase pathway or enzyme. Cyclooxygenase produces prostaglandin, thromboxanes, and prostacyclin. All of these are prostanoids. On the other hand, the lipooxygenase pathway produces leukotrienes. Leukotrienes are involved in inflammation as well. For example, leukotriene B4 is associated with attraction or activation of phagocytes. Leukotrienes C, D, and E can cause alteration of vascular permeability, bronchial constriction, and increased secretion, leading to bronchospasm, congestion, and mucus plugging. Now, focusing on the cyclooxygenase pathway, we know that the prostaglandins also can cause modulation of the leukocyte to activate the inflammatory pathways. In addition to that, also they cause changes in the bronchial tree, causing increased edema or permeability, increased constriction, and increased secretion. We have some drugs that target all of these different pathways. Let's start upstream. The phospholipase enzyme is actually inhibited by corticosteroids. The lipooxygenase enzyme is inhibited by lipooxygenase inhibitors. While the focus of our talk today is the cyclooxygenase enzyme, which can be inhibited by non-steroidal anti-inflammatory drugs or aspirin. So by blocking this pathway, we will have less prostaglandin synthesis and less modulation of the inflammation. So let's remember that also we have two isoforms of cyclooxygenase enzyme. Cyclooxygenase 1, which is existing in the tissues as a constitutive form. And then we have cyclooxygenase 2, which is the inducible form, is mainly present at the site of inflammation. When we have stimuli, such as cytokines, that can induce the action of cyclooxygenase to produce inflammatory prostaglandin proteases, superoxide. Inhibiting both of these isoforms will inhibit the production of their products, which are prostaglandins. For cyclooxygenase 1, remember we also have production of thromboxane and prostacyclin, which has important physiological functions. So, when we inhibit these prostaglandins that have important physiological actions and functions, not only do we inhibit the inflammatory pathways, but also we will lose some important functions that they target. Let's give one example here. For example, in the stomach, prostaglandin E is associated with protecting the stomach from excessive acid secretion. It actually causes increase in the mucus protection of the stomach and lowers the acid secretion from the parietal cells. So when we inhibit cyclooxygenase 1 in the stomach, this will lead to an over secretion of HCl or stomach acidity, and will lower the protection of the mucus layer in the stomach. This can explain why we see with some of these drugs a GI irritation side effects. So people thought that if we mainly inhibit the cyclooxygenase enzyme 2, we can avoid these effects on the stomach and only have the beneficial effects of the inhibitory pathway of cyclooxygenase 2 by inhibiting inflammatory prostaglandins and thus inhibiting inflammation. And we were going to be talking a little bit later about cyclooxygenase selective, cyclooxygenase 2 selective inhibitors, because even though they were tailored to decrease some of the side effects associated with cyclooxygenase 1 inhibition, but they have some distinct side effects of their own. So again, to revise about the cyclooxygenase enzyme, it comes in two isoforms, 1 and 2. Inhibition of cyclooxygenase 2 is thought to be due to the anti-inflammatory actions of Nsaids, while inhibition of cyclooxygenase 1 is responsible for their GI toxicity. Now, the drugs that we use that are members of the Nsaid family are mainly selective for cyclooxygenase 1. But as we said, we tried to develop newer drugs that are targeting only cyclooxygenase 2. So again, Nsaids share common activities in inhibiting pain, fever, and inflammation. How do they perform these actions? Their anti-inflammatory action is by decreasing the vasodilator prostaglandin E and prostacyclin. This leads to less vasodilation and indirectly causing less edema. The inhibition of adhesion molecules as well, and inhibiting accumulation of inflammatory cells. The analgesic effect happens because we have decrease in the prostaglandin generation. Thus, this means decrease in the sensitivity of the nociceptive nerve endings to inflammatory mediators. Additionally, these drugs can relieve headache because they decrease the prostaglandin-mediated vasodilation in the brain or in the head. Their antipyretic effect is mainly due to decrease in the mediator production, again the prostaglandin. This prostaglandin is responsible for elevating the hypothalamic set point for temperature control in the fever. So one important drug of this family is aspirin. Aspirin is actually the prototype of non-steroidal anti-inflammatory drug. It causes irreversible activation of both cyclooxygenase 1 and 2. It was officially approved for use in 1939. Aspirin comes from a natural source. It's modified natural source. It actually comes from acetylsalicylic acid. Acetylsalicylic acid is one of the important constituents of the bark of the willow tree, اللي هو لحاء شجرة الصفصاف. So we talked earlier about the use of these natural products very long time ago by the ancient Chinese. So they used to use the bark of the willow tree to ease up the pains and inflammation in people. And of course, we did not know what were the constituents of that bark at that time. Later on, early in the 20th century, a scientist synthesized acetylsalicylic acid. The scientist's name was Hoffman, and this was actually the first use of these agents in inflammatory condition. He actually developed this drug to use it for treatment for his dad who has rheumatism or rheumatoid arthritis. Aspirin is one of the most commonly used anti-inflammatory agents, and all the other NSAIDs are usually compared to aspirin because it is the prototype of this group. It is a weak organic acid. One special characteristic of aspirin that it irreversibly inactivates cyclooxygenase, while all the other NSAIDs are reversibly acting. How it is metabolized in the body: it's deacylated by esterases to produce salicylates, which has anti-inflammatory, antipyretic, and analgesic effects. Again, the effects of aspirin are actually very similar to the effects of all the group. So it works primarily by the blockage of prostaglandin synthesis at the thermoregulatory center in the hypothalamus and also at the peripheral target sites. It can also suppress the pain at subcortical sites in the brain. So the main action of aspirin: it is an anti-inflammatory drug, it's an analgesic drug, and it causes antipyretic or reduction of fever. To explain a little bit more on how these analgesic action work, remember we talked about prostaglandin E2, which is known to sensitize the nerve ending to the action of bradykinin, histamine, and other chemical mediator released by the inflammatory process. So when we inhibit the production of this prostaglandin, we will desensitize the nerve ending and thus decrease the pain sensation. So it is used actually for the management of pain of low to moderate intensity, especially that arising from musculoskeletal disorder rather than that arising from the viscera. So it's mainly used for muscle pain, headaches, um, bone pain, but visceral pain or deep pain usually requires much higher efficient treatment, and we can do that by opioids. To explain a little bit further on the antipyretic action, remember that fever occurs when the set point of the anterior hypothalamus thermoregulatory center gets elevated. Now, when we stop or inhibit the prostaglandin synthesis and release, we can cause resetting of this thermoregulatory center back to normal. So, prostaglandin E2 aids in resetting or elevating the thermoregulatory center point, and by inhibiting prostaglandin E2 synthesis, we have a resetting back to normal. So this drug actually rapidly lowers the body temperature in febrile patient, and they do not have effect on normal body temperature. So if you give these agents to a patient with fever, he will have a reduction in his fever, but if you give it to a normal patient, you will not decrease the temperature below normal. These sorry aspirin actually have some other effects, some respiratory effects at therapeutic doses. Aspirin can increase alveolar ventilation, causing uncoupling of oxidative phosphorylation. This can lead to elevated CO2 and increased respiration. On the other hand, when we increase the doses more, it will work directly in the respiratory center in the brain, in the medulla. This will result in hyperventilation and respiratory alkalosis. At toxic level, we will have paralysis of the respiratory center leading to acidosis. The gastrointestinal effect: we said prostaglandin E2 can stimulate the synthesis of protective mucus in both the stomach and small intestine. In the presence of aspirin, these prostanoids will not be formed. This will result in increased gastric acid secretion and diminishes the mucus protection. One of the drugs used to resolve this problem. Now, if we have a patient who have to use aspirin or other NSAIDs, he has a problem with increased acid secretion with these agents, we can give him a group of agents called proton pump inhibitor. These drugs are mainly inhibiting gastric and duodenal ulcers, so they will prevent this side effect associated with the use of non-steroidal anti-inflammatory agents. One special effect of aspirin, it has effects on platelets. Remember, we said cyclooxygenase 1 produces thromboxane. Thromboxane enhances platelet aggregation. So, at a low dose, they found out that daily administration of a low dose of aspirin can irreversibly inhibit thromboxane production in platelet. Now, remember that this drug is working irreversibly. So, how long will the action of this drug persist? Usually, for irreversibly acting drugs, the action of the drug will stop after the body produces the new enzyme that it was inhibiting. Now note for platelets, the platelets they lack nuclei, so they cannot synthesize the new enzyme. So the effect of aspirin on thromboxane inhibition persists for the lifetime of the platelet, which is about 7 days. This can result in prolonged bleeding time, so we have to be careful about that. Non-steroidal anti-inflammatory drugs also have some actions on the kidneys. As you remember, we said cyclooxygenase 1 can induce the production of prostaglandin E2 and prostacyclin, which is prostaglandin I2. These are responsible for maintaining renal blood flow. So some people, when we inhibit the cyclooxygenase 1 inhibiting the production of these prostaglandin, they have interstitial nephritis, or sometimes they have kidney injury because of reduction of renal blood flow. Additionally, the effect of prostaglandin inhibition can result in retention of sodium and water, which may lead to edema and hyperkalemia in some of patients. Now, what are the therapeutic uses or indication? We said they are anti-inflammatory, antipyretic, and analgesic. So, salicylic acid derivatives such as aspirin is used in the treatment of gout, rheumatic fever, osteoarthritis, and rheumatoid arthritis. Additionally, they are used in the treatment of headache, arthralgia, myalgia, so any kind of pain associated with the musculoskeletal system. An external use of salicylic acid is used topically to treat corns and warts because it have a keratolytic ability. Some cardiovascular applications, aspirin is used to inhibit the platelet aggregation at low doses. It's used prophylactically to reduce the risk of transient ischemic attack or stroke or death. A lot of patients actually who have history of cardiovascular diseases, who have hypertension, or even elderly patients who have diabetes are prescribed aspirin because it have these prophylactic effect on protecting the cardiovascular system from having ischemic attacks or thrombotic events. Also, effects of it reduce the risk of death in those having an acute myocardial infarction or angina. Talking about the pharmacokinetics of aspirin, after oral administration, the unionized salicylates are passively absorbed from the stomach and the small intestine. Also, they can be supplemented as a suppository, so we have rectal absorption of salicylate, which is kind of slow and unreliable, but it's actually very useful in children who are vomiting. It's very important to remember one note here. Salicylate should be avoided in children and teenagers below the age of 15, sometimes we say 12, who have a viral infection such as varicella, chickenpox, or influenza, because the use of salicylates has been associated with a syndrome called Reye syndrome. Reye syndrome can be actually a fatal disorder. The reason for this syndrome is not known, but it can happen in children who are using salicylates in addition to having a viral infection. So in general, we can say we avoid the use of aspirin or other salicylate containing drugs in pediatric patients below the age of 15, especially if we are suspecting a viral infection. So in this case, we can use paracetamol. Paracetamol is one of the safest drugs to be used, and actually in this case, it's much safer for those children. Now about the doses, I'm not going to be worried about memorizing the doses of each of the different drugs, but remember, for aspirin, We usually use a higher dose than that used for the antiplatelet activity. يعني إذا if I want to give a patient analgesia or anti-inflammatory activity with aspirin, we use a dose of 325 or even higher, 2 tablets of 325. For anti-inflammatory effect, even we can go up to 3 grams per day. Now, on the other hand, for myocardial infarction or prophylaxis, the dose is 81 milligram per day. Sometimes we can recommend giving 2 pills of the 81 milligram tablet, so it can come up to 162 milligram per day. So, to summarize, for use as an antiplatelet activity, we use doses lower than 325 milligram per day. Usually the recommended dose is 81 milligram. For the use for anti-inflammatory conditions, for analgesia, we use a dose higher than 325 milligram. Now we talked about the adverse effect. The main adverse effect is the gastrointestinal adverse effect. It can cause epigastric distress, nausea and vomiting, sometimes microscopic GI bleeding. Other side effects, we said in the blood it causes inhibition of platelet aggregation, so it can cause prolongation of the bleeding time. We talked about the respiratory system at toxic doses. Salicylate causes respiratory depression and leading to metabolic acidosis. Some people have hypersensitivity reactions to salicylates. Approximately 15% of patients taking aspirin experience hypersensitivity reaction. The signs of hypersensitivity reaction include urticaria, bronchoconstriction, angioedema. We talked about Ray's syndrome, where we said that aspirin and other salicylates given during a viral infection has been associated with increased incidence of Ray's syndrome, which is often fatal, can cause hepatitis and cerebral edema. We said this is encountered in children, should not be given aspirin or salicylates, but rather so given paracetamol or acetaminophen. Important drug interactions. Remember that salicylate is protein bound. That means 90 to 95% is bound to plasma protein. So any drug that also binds to albumin and plasma proteins will also have drug interaction with aspirin. Example of these drugs: warfarin, phenytoin, valproic acid. This will increase the free concentration of both of these agents. So we have to be careful about co-administering aspirin with these important drugs such as warfarin, which is an anticoagulant, phenytoin, and valproic acid, which are drugs used to treat epilepsy. Do we use aspirin in pregnancy? Actually, aspirin is classified as category C in the first and second trimester, category D in the third trimester. Usually we avoid their use in pregnancy, even though sometimes in women who have experienced miscarriages because of the rejection of the fetus, because of the formation of antibodies against it, sometimes we encourage the use of a low dose of aspirin the first trimester to increase the circulation to the fetus. Toxicity associated with aspirin is called salicylism. It is manifested in the form of nausea, vomiting, marked hyperventilation, headache, mental confusion, dizziness, and tinnitus. Sometimes we have to take mandatory measures such as intravenous administration of fluid, dialysis, and correction of the acid-base electrolyte imbalance. Okay, other non-steroidal anti-inflammatory drugs, and we're going to go through these very quickly. We have propionic acid derivative. Examples are ibuprofen, naproxen, phenoprofen, ketoprofen, fluprufen. All of these drugs share the same mechanism of action. They are inhibitors of the cyclooxygenase enzyme. So they will have anti-inflammatory, analgesic, and antipyretic activity. Their GI effects are generally less intense than those of aspirin. Another difference is that they are reversible inhibitors of cyclooxygenase. They can be administered orally. Also, they are bound to plasma protein. Their metabolism, they undergo hepatic metabolism and excreted from the kidneys. The main common side effect of these agents is the GI irritation. It starts from dyspepsia but can reach GI bleeding. Additional side effects in the central nervous system, they can cause headache, tinnitus, dizziness. The pregnancy category, they're category C and category D from the third trimester. They can increase the risk of cardiovascular, thrombotic event, myocardial infarction, and stroke. They can increase the risk of GI bleeding. The dose of ibuprofen should not exceed 3,200 milligrams per day. It should be given with food and water to avoid the GI irritation. Their use of asthmatic patient is contraindicated, or it has to be given in caution. Why is that? Remember when we talked about the cyclooxygenase and the lipooxygenase arms of the arachidonic acid pathway? If we inhibit one arm of the pathway, the other arm will be activated, or it will show more activity because it will have more availability of the substrate for that other pathway. So when we inhibit the prostaglandin synthesis, more leukotrienes will be produced. And remember that the leukotriene production can exaggerate an asthmatic response because it causes bronchospasm, bronchial edema, increased secretion. So all of these are gonna be bad for an asthmatic patient. The next group are acetic acid derivatives such as indomethacin, sulindac, etodolac. Again, all of these are cyclooxygenase inhibitors, so they will have anti-inflammatory, analgesic, antipyretic activity. They are potent as anti-inflammatory agents, but because of toxicity of indomethacin, it's not used so much for treating anti-inflammatory properties. We have oxyam derivatives, piroxicam and meloxicam. They're mainly used to treat rheumatoid arthritis, ankylosing spondylitis, and osteoarthritis. Because they have a long half-life, they're used only once a day. Meloxicam is an inhibitor of both cyclooxygenase 1 and cyclooxygenase 2, but it has preference for cyclooxygenase 2, so it's considered somewhat a selective inhibitor of the cyclooxygenase 2 enzyme. So at low to moderate doses, it will show less GI irritation than other non-steroidal anti-inflammatory drugs and piroxicam. We have the phenamates, such as mefenamic acid. They don't have added advantage over other non-steroidal anti-inflammatory drugs, so they share the same mechanism of action, the same effects. Side effects can include diarrhea, which can be severe, so they can be associated with inflammation of the bowels, and also cases of hemolytic anemia have been associated with these agents. We have a group of drugs called heteroyl acetic acid. From these group of drugs, the famous diclofenac, sodium and diclofenac potassium. They are mainly used for long-term treatment of rheumatoid arthritis, osteoarthritis. Diclofenac is more potent than indomethacin and naproxen. We can use it also in ophthalmic preparation. Because diclofenac accumulates in the synovial fluid, it is highly recommended for use in the inflammatory conditions of the joints. It's used in different formulation. For example, orally, we can use it as 50 milligram after food. It can be used as an IM injection of 75 milligram. Diclofenac potassium is a prompt release, has quicker onset of action than diclofenac sodium. In relation to pregnancy, all of these agents are category C. Other side effects associated with diclofenac sodium, it can cause hypersensitivity. We have to be very careful about the use of these agents in asthmatic patients and patients who have history of peptic ulcers. So these are the contraindication of diclofenac sodium. The metabolism is mainly in the liver, excretion mainly in the urine. The use of selective cyclooxygenase 2 inhibitors. We have 3 examples here. We have celecoxib, meloxicam, and rofecoxib. So to talk about these drugs historically, these are kind of new drugs. They were developed in the late 20th century, approved early the 21st century, so around the year 2000. They produced the 2 drugs, celecoxib and rofecoxib. They are selective for cyclooxygenase 2 rather than cyclooxygenase 1, and the reason for their development is to avoid the GI side effects associated with non-selective inhibition of cyclooxygenase. Now, what is the problem with these agents is after their release in the market, rofecoxib was actually withdrawn from the market because it was associated with deaths related to thromboembolic events. While celecoxib is still in the market, it's available in different commercial forms such as Celebrix. So it is indicated for the use of chronic inflammatory conditions such as rheumatoid arthritis, and because it is inhibiting the inflammation, inhibiting the pain without causing the bothersome side effect of non-steroidal anti-inflammatory effects. But what are the side effects of this agent? Again, this agent can be associated with thromboembolic events. Why is that happening? Remember, we said when we inhibit one arm of the pathway, we activate the other arm. Remember that the cyclooxygenase 1 pathway is associated with thromboxane production. Thromboxane causes platelet aggregation. So when we inhibit cyclooxygenase 2 enzyme, we have more thromboxane production, more platelet aggregation, so more risk of the patient for the development of thromboembolic event. That's why there is a black box warning on celecoxib that says that you have to be careful about the use of this agent if you are prone to thromboembolic events. Of course, these drugs should be prescribed according to the doctor prescription. So what do we mean by black box warning? Black box warning is a very serious side effect that it has to be written on the outside of the drug box. So احنا بنعرف that usually drugs have a lot of side effects, and if you read the leaflet of the drug, you're gonna see these big number of side effects. But if we have a serious side effect such as this side effect, which is thromboembolic event, you have to warn the patient ahead of time. So this warning is put on the outside of the box, and it gives a very important warning for the doctor, for the patient, that if you are not recommended this kind of treatment or category of treatment, that you should avoid the use of this agent. Now we said acetaminophen is a distinct group of analgesic. Acetaminophen inhibits prostaglandin synthesis in the central nervous system. That's why it has antipyretic and analgesic property, but not so much anti-inflammatory property. So it has the least effect on cyclooxygenase in the peripheral tissue, which accounts for this weak anti-inflammatory activity. Additionally, it does not affect the platelet function or affect the bleeding time. It is suitable substitute for the analgesic and antipyretic effect of aspirin in those patients who have gastric complaints and in those patients who have prolongation of bleeding time. Additionally, acetaminophen is the drug of choice for children with viral infection or chickenpox who have high fever. Remember that we cannot use aspirin in these cases because of the risk of Ray's syndrome. Now, what are the pharmacokinetics of acetaminophen? It's rapidly absorbed from the GI tract. It undergoes significant first-pass metabolism in the luminal cell of the intestine, and also in the hepatocytes. Usually, acetaminophen can be hydroxylated to form N-acetylbenzoiminoquinone, which is highly reactive and can be dangerous metabolite that is toxic for the liver cells. At normal doses, N-acetylbenzoiminoquinone reacts with the glutathione system to form a non-toxic substrate. But when we take too much of acetaminophen, this can lead to accumulation of the toxic metabolite. That's why it's very important to monitor the dose of acetaminophen given to patients. While acetaminophen is a very safe drug, but if given at high doses, what high doses are we talking about? Usually, the dose available in the market for adults is 500 milligram. A lot of us take acetaminophen for headache, for example, for other kind of muscle pains, for cramping. We can take sometimes 2 pills of acetaminophen, which is the dose that's recommended on the leaflet of the drug. So you can say 1 to 2 pills of acetaminophen. Now, let's say a patient have this chronic pain and he wanted to take more of that drug. It's very easy to cross the safe dose. What is the safe dose of acetaminophen? It's up to 4 grams. So 4 grams equals 8 tablets of the 500 milligram acetaminophen. Let's say you have a headache and you're taking acetaminophen according to what the leaflet prescribed. It's 1 to 2 pills every 6 hours. So it's very easy to reach that 4 milligram, which is where we say this is the limit for safety, and above that we can start to see toxicity. Why is toxicity happening with acetaminophen? Again, this is because of accumulation of the metabolite of acetaminophen in the liver. So, with normal therapeutic doses, acetaminophen is free of any significant adverse effect. While some people say that renal tubular necrosis and hypoglycemia can happen as a complication of prolonged large dose therapy, but these are very rare. On the other hand, large doses of acetaminophen can cause hepatic necrosis, which is a very serious, potentially life-threatening condition. The treatment for this, or the antidote, is acetylcysteine, which is gonna scavenge these toxic free radicals. This treatment is effective if given within 8 hours, up to 12 hours of the overdose of acetaminophen. After that, we're gonna start to see signs of pathology or necrosis of the liver.